Okay, hello again. Welcome to a new BCC online lecture. Today we are going to review hypertension. As usual, here you have the objectives of the lecture. We will review the definition of hypertension, how it's measured after the last protocol, the different types, the etiologies, risk factors, and clinical manifestations associated to it, these strategies of management, and a quick review of a special condition named hypertensive crisis. Hypertension or high blood pressure affects over 1,000 million people around the world, which is 1 billion for some English-speaking countries. Now, normal systolic blood pressure is defined as less than 120 millimeters of mercury, and normal diastolic pressure is less than 80 millimeters of mercury. Elevated blood pressure is when systolic blood pressure is between 120 and 129 millimeters of mercury and less than 80 millimeters of mercury on the diastolic side. We define stage 1 hypertension as the one between 130 and 139 on the systolic side and between 80 and 89 on the diastolic side. Each stage 2 hypertension is defined as anything that is 140 or higher on the systolic side and 90 or higher on the diastolic side. Typically, both systolic and diastolic pressures tend to rise or fall together, but that's not always the case. Sometimes you can have systolic or diastolic hypertension when one number is normal and the other is really high. This is referred to as isolated systolic hypertension or isolated diastolic hypertension. Now, there are two main types of blood pressure measurements: office blood pressure, which is taken in a clinic, and out-of-office blood pressure. The out-of-office blood pressure can be either home blood pressure, which is taken by the patient at home, or an ambulatory blood pressure monitoring, which involves a 24 hours monitoring of the blood pressure to see if that pressure falls at night compared to during the day. And it uses a small digital blood pressure device that is attached to a belt around the body, and it's connected to a cuff around the upper arm. Ambulatory blood pressure monitoring is the best way to diagnose hypertension, but it's not always feasible, and it's usually done when the office and home blood pressure measurements are really discordant from one another. Now, the first step for an office blood pressure is to make sure that the patient has rested for at least 5 minutes and is properly positioned, sitting with the arms and back supported and the feet flat on the floor. This measurement should be repeated at least 2 times. Most of the time, blood pressure is taken in the brachial artery in the upper arm, because if the pressure is high there, it's probably is high throughout the arteries. And also keep in mind that just being in the office can cause blood pressure to change, normally to rise. So the diagnosis of hypertension should be done by looking at both office and out-of-office blood pressure measurements. As you see, getting the right numbers for blood pressure is not that simple, and even when you're having proper numbers, there are still many other factors to have in mind before deciding to give medication that has side effects to a patient. We will see that later on in the seminar with that doctor you already know, your cardiologist, that is going to address this matter. As you know, the second important step is taking the patient's history and physical examination to have a clear picture of a patient with hypertension. But now let's continue with the disease, and we'll go back to that. Now, there are two main types of hypertension. Primary or essential hypertension has clear, no identifiable underlying reason, and secondary hypertension, which does have a specific underlying condition. So primary hypertension is way more common, is about 90% of the cases, and it generally is not accompanied by symptoms. It's sometimes called a silent killer because over time pressure in the arteries silently creep up and causes blood vessel damage, which is you already know is a risk factor for atherosclerosis that may lead you to myocardial infarctions, aneurysms, or strokes. So risk factors for primary hypertension include old age, obesity, family history, a salt-heavy diet, sedentary lifestyle, heavy alcohol consumption, smoking, and also race. Because, for example, people from African descent are more likely to develop hypertension. Some of these risk factors can be improved with lifestyle changes. Now, less frequent secondary hypertension often is accompanied by a variety of symptoms associated with the underlying cause. In general, the younger the patient, the more likely is secondary hypertension. For example, anything that limits the renal blood flow can cause hypertension, like in young women, fibromuscular dysplasia, but also atherosclerosis in older patients. Other examples include obstructive sleep apnea, atherosclerosis, vasculitis, or aortic dissection, as well as endocrine disorders like pheochromocytoma, which is a catecholamines releasing tumor, or Cushing's syndrome, which is an oversecretion of cortisol. Remember that the kidney is part of the renin-angiotensin-aldosterone axis that regulates blood pressure. So any condition that restricts the blood flow through the kidneys is interpreted like a lack of pressure. The kidneys will secrete renin and water will be reabsorbed. In the same way, a tumor that produces aldosterone will make the kidney to reabsorb water. So you reabsorb more water, that means more blood volume, and that means more pressure. It's also important to identify signs of end organ damage and whether the patient takes any medications or exogenous substances that can worsen hypertension, like sympathomimetic agents like decongestants, or even cocaine, cyclosporin, sodium-containing antacids, stimulants like amphetamines or antidepressants, oral contraceptives, that in the case of women, and even NSAIDs or licorice, that delicious cherry black candy. So basal metabolic panel and electrocardiography should be performed to screen for secondary forms of hypertension. In respect to the basal metabolic panel, which is a set of tests, here you have what is checked. And well, by now you should already know the importance of every substance like glucose, calcium, or any of the electrolytes. Okay, any alteration of these measurements will have consequences. Okay, like as we saw with the kidney lecture, blood urea nitrogen, or the famous BUN, and creatinine. So management for hypertension is mainly based on the hypertensive stage, the patient is, the risk of developing cardiovascular events and organ damage, as well as taking into account any concomitant disease like diabetes or chronic kidney disease. As you know, lifestyle changes are crucial for all patients, especially in the long term, and include things like quitting smoking, moderated alcohol drinking, maintaining healthy weight, reducing dietary sodium, and staying physically active. Have in mind that not all patients with hypertension need antihypertensive drug therapy. In fact, medication is generally suggested only for patients with an out-of-office blood pressure higher than 135 systolic or higher than 85 diastolic, or office blood pressure higher than 140/90. It's also recommended for patients with an office or out-of-office blood pressure higher than 130 systolic or 80 diastolic, who also have other features. Especially, they need to have at least one of the following: cardiovascular disease, type 2 diabetes mellitus, chronic kidney disease, be over 65 years old, or have an elevated risk of coronary artery disease that we will see in the next lecture. On the flip side, it's generally recommended not to give antihypertensive medication to patients with stage 1 hypertension that are either over 75 years old or have no organ damage. Respect to the medications, there are 4 main classes of medications that are used to treat hypertension. First one is angiotensin converting enzyme inhibitors. Then we have angiotensin receptor blockers, diuretics, and calcium channel blockers. There is a lot of variability in terms of how individuals respond to different medications. So it's important to follow up to see how the medications are working. And of course, it's very important to be sure the medication is needed. There is nothing after a lifestyle change. Finally, if the blood pressure gets really high, really fast, it's called an hypertensive crisis. In a hypertensive crisis, either the systolic pressure is greater than 180 millimeters of mercury, or the diastolic pressure is greater than 120 millimeters of mercury. Hypertensive crisis can be further split into hypertensive urgency and hypertensive emergency. With hypertensive urgency, there hasn't yet been damage to end organs like the brain, kidneys, heart, or lungs. But in a hypertensive emergency, there is damage to end organs, and the patients have symptoms like drowsiness, chest pain, or dyspnea, which is the difficulty to breathe. The most common cause of hypertensive crisis is not taking the antihypertensive medications when the patient is on medication. But it can also be due to causes like secondary hypertension, like renovascular disease, pheochromocytoma, and hyperaldosteronism, as we already said. You know that for the treatment, it is important to gradually reduce the blood pressure over 1 to 2 days to make sure that the brain doesn't get underperfused. So treatment for a hypertensive urgency is done with oral medications like ACE inhibitors, while in a hypertensive emergency, the goal is to lower the mean arterial pressure by 20% within the first hour, and the treatment is to give intravenous medication like beta blockers, calcium channel blockers, and vasodilators like nitroglycerin, that you will see is very important in the coming lecture about angina pectoris. So thank you very much for listening, and now let's go back to the streaming connection.
That's all, folks.